everyone. This is the Shelbourne Knee Center podcast. This is Dr. Benner, and we're back for another week talking about another knee-related topic for all of you out there. If you'd like to catch us on social media, you can find us on Facebook and YouTube at the Shelbourne Knee Center podcast pages on those avenues. You can also pick us up on Twitter and Instagram at the SKC Podcast, or you can email us at the skcpodcast@gmail.com. If you like what you hear for any of our content, go back and check really any podcast avenues that you want to utilize, and leave us a 5-star review if you like what you hear.
Before this episode, we want you to go back and listen to last week's episode if you haven't. We talked about the effect that preoperative flexion has on postoperative flexion after a total knee, and we covered a study that we recently had at some of the national conferences and discussed the ways that preoperative flexion affects postoperative flexion. So go ahead and go back to that episode if you can. And for today's episode, we have a great guest, Dr. Fred Azar. He's going to be joining us tonight, and we're going to be discussing the management of NBA athletes when it comes to their medical care.
So Dr. Azar was the residency director when I did my residency at the Campbell Clinic, and he was a real good mentor for me while I was coming up. Lots of times when I ended up in his office asking me, Fred, where should I go to do my fellowship? Fred, where should I go work when I grow up? What should I do? And door was always open, so always appreciated the counsel of Dr. Azar, always available. Dr. Azar is a sports medicine specialist at the Campbell Clinic in Memphis, Tennessee. He is the chief of staff at the Campbell Clinic and is also the director of the sports medicine fellowship program there as well. He served as the team physician for the Memphis Grizzlies for 22 years and was selected as the 2012 team physician of the year by the NBA. He's also former president of the NBA Physicians Association and is a consultant for NBA. So over the last 25 years, Dr. Azar has been involved in multiple different societies, been president of the American Academy of Orthopedic Surgeons, and you name it in orthopedics, Dr. Azar has done it. So it's a pleasure for us to have a personal mentor of mine and a professional mentor, as well as just a real influential person in orthopedics on the podcast tonight. So Dr. Azar, thank you for joining us.
Thank you guys for having me. And so Rodney, you opened the door for a lot of IU folks for residency programs. So but you did such a great job. You've established a little bit of a legacy. So we've had some really great residents and fellows come and train from Indiana University. So
hopefully all good. Hopefully they represented us well. So
sure.
Very good. Well, Dr. Azar, we mentioned that you were team physician for the Memphis Grizzlies for 22 seasons, and you're now a consultant for the NBA. And that's really what we wanted to talk about tonight. When I thought about what could we talk to Fred about, I thought, the specifics of taking care of NBA athletes, specifically knee injuries and NBA athletes, is one that really came to the forefront that I thought would be great perspective for you to have for our listeners. So let's just start off with, you go to medical school, you end up in orthopedics, and you start to think about what kind of career you want to have in the future. What really led you to sports medicine, and how were you really brought up in this field?
Well, orthopedics is great. There's so many great ways to take care of patients, and it's really a privilege to be an orthopedic surgeon, a really blessing. The sports medicine came about, I was looking at several different subspecialties, but at the end of the day, it was you wanted to be able to take care of some people that wanted to really get back in the game, get back to work, get back to play and sport. And they were motivated just like you were to get them back. So that attracted me, I think, to sports medicine.
And, you went and did your residency, your fellowship after the Campbell Clinic was done with Jim Andrews down in Birmingham, and talk a little bit about his influence and just your experience down there and how that led you on to your future.
Yeah, I was fortunate to train with Jim Andrews and Bill Clancy, another great mentor. Both those guys were really, it was a privilege to train with them. And it was really, I think, prime time for at least for Dr. Andrews, seeing really just about everybody's revolving door of professional athletes that were coming through there.
Yeah.
I guess prime time for him lasted a long time. In fact, his whole career just recently retired the last year. So, but it seemed like it was prime time because all the people, all the who's who in sports would come through there for to be treated, for another opinion. So there was always something going on.
And who were your mentors in the sports medicine world at the Campbell Clinic?
Well, Terry Canale and Dave Sisk were the two people here. I'm very fortunate to have people like that here. I also did a traveling fellowship with my godfather was Freddie Fu. He was another mentor in sports. So I've been really fortunate along the way to have really great mentors.
So as we dive into taking care of NBA athletes as it relates to their knee injuries, we like to think we treat everybody the same, but there's undoubtedly some differences depending on what kind of population that we're dealing with, whether someone's a weekend athlete, a high school athlete, to the collegiate ranks and then on to the professional ranks. And it's something that I don't have much exposure to. And most of our listeners have not been a team physician for an NBA or other professional franchise either. So what would you say are the big differences that you learned over time that there were taking care of NBA basketball players as opposed to lower ranks of competitive sport or even recreational athletes?
Well, I used to say there was an urgency to getting the diagnosis and getting a plan. This trickled down now to the collegiate level, and for sure, and even some select high school athletes too, with the NIL too. All that sort of stuff is really, it's interesting. It's almost like a pro level at a lower level, but really it's the stakes, the stakeholders. There are many stakeholders that come with an NBA player, and it's high stakes for that player. This is their livelihood, and I like to tell my residents and fellows, there's an E before, there's an ESP, it's ESPN, not SEPN. Entertainment comes before sports. It's a business. Mm-hmm. And you have to realize that. And when you're dealing with an athlete, you have to, the most important thing to establish is trust. And if you're in a locker room with a team, the culture is critical. And that's not something that really happens overnight. It happens over a period of time. And the way you really defined, the medical staff's really defined how they handle an athlete's injury. Everything's sort of the honeymoon period. Everything's jovial in the locker room, the training room. When somebody gets hurt, it becomes really personal, and that's really how you're defined as to how you are able to take care of that athlete. It's not just the physician. There's a whole team of people surrounding that athlete. Mm-hmm. So that part is important. As a team physician, you're ultimately responsible for the care of that athlete. So you have to, communication, in addition to culture, communication's critical. And you should have a communication plan in place. Every team usually does, how they would address a player's athlete and how to communicate both internally and externally. Certainly, in these days, the players choose to communicate on their own externally through social media. I always think about Herm Edwards when he was giving a speech to the NFL rookies in training camp when he just said, "Don't press send." So you can type up whatever you want on your social media, but
just don't do it.
maybe sleep on it. But so that's up to the athlete, obviously. But the approach is, you have to have that culture there. They have to have that trust, and it comes over time with respect and with professionalism. That happens, has to be earned. And then when someone has an injury, then you have to lean into that, and you got to get a plan. And the plan is they have something that if you do work comp, they talk about. This is the ultimate work comp, obviously. They talk about forecasting. So mm-hmm. If somebody has an injury, and you say, okay, this is where your return to play is approximately here. This is what it's going to take to get there. It may be rehab, maybe surgery with rehab, and these are the milestones. And you have to project some sort of a time period. Sometimes it's just not known, and it depends on the time of the season too. But you have to project how long it's going to take to get them back to play, full return to play, and all the milestones that come along with that. And you have to be flexible because things don't always happen like they're supposed to. So, mm-hmm. So you need to have that culture in place. You need to have a communication plan in place. You also need to have the plan to get them back to play.
Yeah, I can tell you from my experience taking care of athletes at the high school level, at the Division III level, and then 10 years of taking care of Purdue at the Division I level, a couple things that I thought were really interesting that you brought up there. One is and I'm sure you've experienced this, that the athletes want something, quote, done, and the coaches want something done. We have to do something. And as you know, oftentimes when athletes come in with non-surgical injuries, overuse injuries, things like that, sometimes the answer is you just got to rest and you got to wait. And they don't like that answer at all. And especially difficult with something where we need to wait and see where this goes for a period of time before we decide on whether or not we need a surgery. And often that is met with a lot of consternation from the coaching staff, especially, as well as the players and parents, that, well, if I'm going to have surgery, I want to do it right now. I don't want to wait 6 weeks and then find out that it's not getting better and then need surgery. And unfortunately, sometimes that is the best answer, and that is our recommendation. So that's something that I've struggled with personally, is that communication piece that you talked about, and involving everybody in the decision, but also understanding that, doing something isn't always better than doing nothing. But athletes and coaches don't look at it like that. And then secondly, the whole prediction model for how long is this going to take? You get that guy that feels a pop on the inside of his knee, has some tenderness over his MCL, maybe a little laxity. Okay, how long is this going to take me to get it to how long is it going to take me to get back? Well, it might be 3 days. It might be 6 weeks. It might be 3 months. It's hard to predict that all the time, but that's not the kind of things they want to hear. And coming in about some of those return to play criteria and predictions takes into account what kind of player the player is, what kind of attitude they have as far as how quickly they want to get back, and then the coaching staff, how much they're itching and on you for that has to get into play when you tell them those predictions. So a couple things that you brought up there that I know that I've experienced and seem to be markedly different at different levels of play.
Yeah, for sure. It's the art of it. The art of medicine is at play when you're taking care of a professional athlete, because you have to know your player, and different players respond differently to injuries. And some players, or I just want to get back out there, and some they want everything to be just right. You have to respect that. In addition to the biology that's got to happen, there's a psychological readiness that has to happen.
Yeah, no doubt.
You have to consider that. There are also other factors with injuries. There's social issues, and there's different ways to address. When you have an injury, they talk about the biopsychosocial approach to these athletes. I also throw in the spiritual approach, because that resonates to a lot of them too. The higher power in charge, your God's in charge. You're going to be fine. You're going to get back. You're going to learn something from this. You want to be positive, but not. If you want to be positive and confident that they're going to get back, because they are usually going to get back. There are very few career-ending injuries, and it may be the season-ending injuries, because that is something. About 15% of injuries in the NBA are season-ending injuries. It's just a timing thing. So something to consider.
Before this next question, Dr. Azar, I'm going to plug our own podcast here. About a month ago, we had on a physical therapist to discuss specifically the rehab for basketball players and high-level basketball players. He was a guy in physical therapy school that did his internship for the Indiana Pacers for about 3 months, and then he took a sports residency position for a year with the University of Cincinnati men's basketball team. So we did talk to him a month ago, and I encourage everybody to go listen to that. But the insights we gained from him were great, because I was a physical therapist before joining the research side, so I really enjoyed that conversation to see what that looked like at the professional and at the high level collegiate ranks, and it was really interesting from a rehab perspective. Now, obviously, there's a big team, and you alluded to that as well when it comes to the medical care. So can you speak to that? And I know you said the biopsychosocial and the spiritual aspect, and after gaining some insight from Mike on his episode, it starts with the team physician, but then there's a whole multitude of professionals that are helping treat this athlete, everybody from a physical therapist to athletic trainers. And you mentioned the biopsychosocial, like a sports psychologist and nutritionist. And can you speak a little bit to the team and how that is set up? And then second would be some communication strategies that you have found success with when it comes to delivering the message and having everybody on the same page when it comes to carrying out that plan you spoke to.
It's interesting, that when we first started doing this, there was an orthopedic surgeon, a medical doc, two athletic trainers, and a couple of strength conditioning coaches. Now it's transformed into something a lot more. You've got sports performance specialists, you got physical therapists, you've got dietitians and chefs, you've got a sports psychologist that's embedded with the team. You've got PhDs in different types of specialties. You've got data analytics people. All this information really goes in to create some data. A lot of these players, all these players have some sort of baseline data on, and where they are in a normal state. different body parts, and they've all kind of functional movement exams go into all this preseason. So they've got baseline data, so they know what they're looking for to get somebody back. If they're 85% or whatever, they can do that. So that's really important. Data is so huge. They're measuring load. There's a wearable technology. There's all these things out here. They video record everything. There's all kind of technology there. You dump all that data somewhere, and you got AI built into it. Now it's amazing. It's the power that you have there. So those are things to consider. And that at the end of the day, it does fall back on you. And so the communication strategy to the team is it's got to be, first of all, very transparent. It's got to be, you've got to have a plan in place to start. You have to have a transparent plan. You have to have those who need to know, knowing what they need to know about the recovery of that athlete. The most important person we get lost in all this is, at the end of the day, you talk about the athlete, the player. At the end of the day, they're patients. They're patients of ours because they're injured, and you have to. It's the golden rule of medicine. You take care of, treat that patient like you want to be treated. You have to be really cognizant of that. That yeah, it's a business. It's not. You're a part of it, but you got a day job, and you want to respect the fact that it's a business, and you want to respect the fact that there are a lot of stakeholders that want to know what's going on. But if you've got an organized communications plan, again, and the internal communication plan is really important, then it works. And if you need to keep up, if you got a player that's out there, you say we're going to check the person again. When you hear in the media, he's going to be checked again in 2 weeks or 3 weeks. Believe me, you're knowing something. You're hearing from whoever's involved, the athletic trainer or the therapist, 2 or 3 times a day. Sometimes it's when you officially are going to say something to the media. That's code for. Yeah. You'll hear from us. The media. That's the outward communication.
It always fascinated to me at the Division I level, even when Purdue athletes would get injured, we'd see them the day of, we'd make a provisional diagnosis, 6 a.m. the next day, they're in the MRI scanner, 7:30 comes around, it's already been looked at by the radiologist, we have the answer. And then, 2-3 days later, you hear, well, they're still undergoing further testing, we're still wondering some more things, which is not the case. It's just fascinating hearing having what is going on, and then hearing the different things during the media. So speak a little bit about that, on how you handle that situation, which of course is to the nth degree when you're dealing with professionals instead of collegiate athletes.
Well, that's up to the team. That's up to the player. That's up to the agent. I mean, you may know more. You usually know more information what you see out there, and that's some of that's gamesmanship, and some of it's just
absolutely
the players. That's not the privacy of for the player, So that's just how it is, and you have to respect that too, for sure.
This may sound like the most basic of questions, but when you talk about the power of all the data and all the information that you have available to you with the baseline analytics and the in-game analytics and all the professionals that are involved taking care of these athletes, how do you keep everybody on the same page? And you mentioned earlier about people needing to know certain things and maybe not needing to know other things. Where do you draw that line, and how does that go about? Is there a centralized system that you use to keep everybody in the loop, or is this via phone calls, or what?
Yeah, there's technology. There are different apps and things like that you can use that are they're protected, and that's one way that we do a lot of communicating internally. Slack, that's one of the ones that's been used, and things like that. I think that can help you real time, and you know that you're safe to communicate that way, and you're in a small circle too usually. But it's not uncommon though to pick up the phone and talk to your athletic trainer, your therapist, whoever's doing the work there. You have to be available, as 24/7. It's just the way it is. And you talk about getting MRI at 6 a.m. in the morning. Well, not infrequently we would do them. That night. We don't want to wait to the next day, so it's just how it is. Just depends on, the circumstances. So.
Yeah, I always found the apps were definitely helpful because all relevant stakeholders were usually in one place. As you know, you walk through the training room, you see the athletic trainer. Hey, Doc, how's so and so doing? Yeah, I took a look at him. His motion's a little tight, so we need to do this. All right, cool. And then you walk down the hall and you assume that everybody else got the message. The next day, the defensive trainer or the trainer that's working that person most specifically is calling you. Hey, Doc, why didn't you tell me about this? I'm like, I did. Well, no, you didn't. You told him. You didn't tell me. And so I started eventually just getting to the point where pretty much any conversation I had with anybody about everything, I would then kind of brief it on the app where everybody could see it. So there was never, one person heard this, one person heard this. Let's get everybody all the relevant information in real time. So let's jump in specifically on basketball injuries. So as you go through an NBA season, what are some of the common knee injuries that you see in basketball players?
Well, we see MCL injuries, we see patella tendonitis, we see hamstring injuries, we see some meniscal tears. The big ones like an ACL are not as common, but those are the ones that the most common. We just finished a study. There's a research committee that the NBA Team Physicians has that works with the league, that works with the Players Association, and has an epidemiology group, third-party group that really works together. And we're publishing a study. It's all started, by the way, the 2013-2014 season. We're publishing a study that's got 6 years of data. The most common injuries were lateral ankle sprains would be expected, and then followed by hand and wrist soft tissue injuries. But knee and ankle injuries are very, very common in the NBA. And fortunately, most of the knee injuries are self-limiting. There's a bone bruise or an MCL injury, or like I say, hamstring sprain or a meniscal tear. But fortunately, the larger injuries like an ACL or the more significant ones are not as common.
Yeah, patella tendonitis in particular with volleyball players, I think maybe even more than basketball, but amongst the basketball players can really be a bear because nobody wants to come out of the season for something as little, quote little as tendonitis. It's just some tendonitis. Why are they missing so much time? But it's something that can really build on itself and become a chronic problem, and it's one that if not handled correctly can turn from a couple days here, a little bit of treatment and anti-inflammatories, to a chronic problem. The tendon's chronically injured to the point where it won't get better without surgical intervention. And like a lot of things in orthopedics, that there's a bunch of different ways to fix something like there is with patella tendonitis. It probably means none of them are very good. So the recovery from surgery for that particular problem is really a bear. So how do you go about taking care of that if you have an in-season athlete with patella tendonitis?
Well, that's something that's is tricky to do if you've got somebody that's in season who's got depending on the levels. MRI is really, really valuable. Ultrasounds can be done real time, and I think that's a good tool to look at on a every other day or daily basis. But if you want to really track things, but the MRI tells you what's going on, so you know the severity. So the critical thing is it an at-risk condition? At risk being, could they really make this worse? Could possibly even tear the patella tendon? And there's no way to completely predict that. But if somebody's got a pretty high patella tendon, it, and there's not much you can do other than from a return to play standpoint. You have to shut them down, and you have to continue the rehab. That you have to manage it as best you can. If it's something that's mild, you can manage it and let them play and let them recover. And you can decide. With the season, you can pick. Okay, we're going to target this game for return to play in this many minutes, those sort of things. You can do that, but you got to get to that point. They have to be able to practice and go 5-on-5 and all that. All that stuff's done in the background before somebody returns from an injury. It just really depends because tendonitis can be, as you know, it can be very mild, it can be moderate, it can be severe too. So.
When you're talking about the treatment of an athlete with patellar tendonitis, especially as it pertains to basketball players, how often does the time of season matter? I know you mentioned in season's tough because you have to shut them down and target a time to come back. But, I get everybody's different, but, it's late April and they're thinking about a playoff push. Does that factor into the decision with the team, or does it differ based on the time of year that they may have it?
Yeah, it does depend. It depends on what's in front of the schedule. Certainly, the playoffs is a whole other level, and it depends. First of all, the players got to want to be able to be out there, and if you have to make sure they're safe to be out there. If they want to be out there, then you're going to figure out if we're going to manage their minutes and put it in. Or maybe we'll wait to the second round or something like that. You look at there are a lot of variables that go into it, and so that's really important. First of all, the players got to want to do it. Secondly, you got to look to see what's in front of you and see if you can manage it, and if it makes sense to try and get them back in the first round. No, we're gonna make it to the second round. We're not worried about the first round, and that goes into it also. We don't need you for the first round. So those are things that go into it. It's and of course, if you think you're not even going to get out of the first round and you've got something going on, it's probably not worth the risk.
What do you think about the role of biologics in treatment of patella tendonitis, as well as the imaging technologies like ultrasound that you say you may use on a regular basis? That's something that when I was a resident, I don't remember us talking about as much. That now seems to be talked about all the time, and just want to hear your thoughts on that.
I think that it's a really good diagnostic tool in the locker room now. If you got the people that are trained to do it, I think that. From the biologic standpoint, I think there's some data that supports it depending on the location. And as you know, so some of that comes with consequences of time out, period of time before you can return. You have to, typically if we're going to do something like that, we make a decision to do something like that. It's right after the injury, because that's a part of they're going to need a certain amount of time to heal. Go ahead and do the biologic then. Don't wait a couple of weeks, then you set them back even more. So that decision is made early on if you're going to do it, and then if you're going to do it, you'd like to get it done sooner than later.
Let's talk a little bit about ACL tears, the one that everybody dreads the most in getting when you have a professional athlete with an ACL tear. How does the management of that injury differ from high school and collegiate athletes?
It's interesting. The data at the NBA level it's a full season or year back. It's not 6 to 9 months. It's closer to 9 months to a year. It's just the way it is, and it has to do a lot of things. Obviously, that certainly level of play has something to do with it. But there's just so much more that, as you know, the biology happens probably 18 months. It's not happening at 6 to 9 months. Some of our athletes go back, so that's part of it too. There's some data that shows that the psychological state of the athlete around the injury, certainly immediately after the injury, actually predicts how they're going to do, how soon they're going to get back. So that part of it's really important too. But the data shows they usually get back. They're going to get back with it's just going to take them a year, probably full season or a year. And you have to recognize it's just going to take a little longer at that level.
Without name checking anybody in particular, there have been some specific cases of athletes from knee injuries, not necessarily just ACL tears, but ACL tears as well in the NBA that just seem to have taken a long time. And it seems like, the stuff leaks out in the media. Well, he's cleared, but he said he doesn't want to go back. And, that's where I think it gets really, really difficult. I know Dr. Shelbourne talks about when he used to take care of the Colts, everybody's your best friend until you get to about that 6-month mark when we're really starting to return to play. And then all of a sudden, when it's time to get back, well, if I get back, then my contract is about out in another few months. And, how that affects other issues that aren't just playing sports enter into the equation that things can get a little more dicey. So talk a little bit about that, about the kind of the mentality of the player and how variable that can be and its impact on return.
Yeah, like we said earlier, we all discussed this earlier. It's all about the player. Everything's, you want the best thing for that athlete. And part of it has to do with their resilience. There's some studies looking at grit. We've looked at grit in some of our own patients, and there's some studies out there that look at resilience too. And also with the ACLs, there's some studies out there that show that, well, what position you play too has something to do with it. Like the lane drivers are the ones where a lot of these injuries happen. It's a first step or landing or jump shot or the common mechanisms. And those the lane drivers are the ones that are more at risk. So the big guys are, the taller, heavier guys can take a while too to get back. They play a different game, but still because their size has something to do with it. But those that are high flyers, it's a huge mental part of that too, in addition to the physical part. that's got to be certainly considered. Because can they get back to that same type of game, or are they going to play another different type of game? So with the injury.
Now, when it comes to ACL reconstructions for this population, can you speak a little bit about graft choice? And I know there could be a great debate just in the general population of what may be the best choice of graft for a certain athlete or a certain patient. But given the nature of patellar tendonitis, is that something that is discussed preoperatively in terms of what graft is going to be used? If they've had a history of patellar tendonitis, or they're a young player, they have a long career ahead of them, and maybe a patellar tendon graft will be, at least in the short term, a little more difficult to get back. Can you speak to what the general consensus is at the NBA level when it comes to graft choice?
So I at the NBA level, most of the data shows patellar tendon autografts. It's interesting. We always go to these meetings and we talk about what graft selection. I've used every graft in my career, and I keep going back to patellar tendon. And when you really pin people down at a national meeting and you say, what would you use if you use hamstrings for this, that? Well, a lot of people that use other grafts will use patellar tendon for elite athletes, including basketball players. At the end of the day, people always say use what's best in your hands for that athlete. But there's really good data for the patellar tendon autograft in NBA players. You can also argue if they've got patellar tendonitis, maybe you're killing two birds with one stone. You're going to take part of that. Maybe, but I'm sure somebody else with the contrarian would say, well, you're taking a bad tendon and you're using that for your ACL. That's not good either. But the data supports it. I think that's in my own hands throughout my career. You talk to some of the people I mentioned earlier, mentors too, that patellar tendon is the way to go, at least from my perspective, and based on the data too.
Let's talk a little bit about meniscus tears as we marching our way through some of these specific injuries in the NBA. I know there's been some kind of high profile cases of athletes that it's interesting when you do what we do and then you hear in the media, well, they're thinking about different treatment options, one of which is this long of a return versus one of which is that long of a return. We all have, we can it's kind of interesting to try to decipher. I bet they're telling them this and this and this, and maybe they're telling them that. And we all have our own slants on all those things, especially when it comes to medial meniscus repairs, I think is where it gets really dicey, especially in the NBA. And like I said, a few high profile cases. So talk about meniscus tear management in the NBA.
Well, we talk about the second opinion. I don't talk about second opinions. I talk about other opinions because it's never a second opinion. You know how it is, and it depends on who you talk to. If when you've got something that's repairable, and you've got an athlete, depending on the age of the athlete, you want them to be able to have a long career. And we all know that if you can repair somebody's meniscus, it's better for them. Even though that may be, if it's an isolated meniscal tear, even though it has a higher re-tear rate than when you do with an ACL at the same time. At the end of the day, the best thing for them is usually repair. They're going to make the decision. They're going to get their opinions and make the decision, and you got to respect that. That's the way I handle that. The radial tear and the lateral meniscus is another one. I think you got to fix all those, but not all of them are fixed. It just depends on who the athlete is. So.
Yeah, we do things as I'm sure you know from Don Shelbourne's previous studies. We rarely we don't repair many meniscus tears. A lot of them at the time of ACL surgery we end up leaving alone or trephinating, and they end up healing with pretty good rates. And we've published pretty extensively on that. Radiolateral meniscus tear is one that I don't think I've ever repaired a radiolateral meniscus tear. Most of them I feel like are relatively small, but I know I listened to an interesting debate at last year at the AOSSM meeting. Lyle Kane and Jim Bradley and some other people were up front talking about that, and there was pretty broad agreement, especially in football players, especially in the heavy football players, linemen, things like that radiolateral meniscus tears should be repaired at all costs. And it was interesting. Lyle spoke up at one point. He's like, I don't know about that one. I might actually take that one out. And to hear the different perspectives on it was pretty interesting. But there's no doubt that the meniscus tear in the general population seems like something that you handle pretty quickly and people get back to relatively quickly, versus in the high level athlete, sometimes when you talk about repair, then it turns into a 6, 9, 12 month absence from playing sports. And then even after they come back, there's been some cases where people have really struggled on that. So I think that's a really tough one when we're talking about professional athletes.
It's definitely case by case. You can't just say all should be. You can't make these statements that they should all be treated a certain way.
Mm-hmm.
Because it definitely comes down to who the athlete is, at the time of their career, the type of tear. There's so many things to consider. At the end of the day, they're going to make a decision after they get multiple opinions. If they want to get back, they need to get back. They're going to probably go for a mastectomy.
You mentioned multiple opinions, and from talking to people who are involved in professional sports as team physicians, and I experience this definitely some at the collegiate level, often get many disparate opinions, and often the team doctor is not the one that ends up handling this. In particular, where it was difficult for me was when the athlete says, well, I'm going back to, I'm from a different, halfway across the country. It's around Christmas time. I think I'm going to have my surgery done at home. And then all of a sudden, when they're back next semester, a month out from surgery, maybe with a graft that you would not have used, a technique you would not have used, a brace you don't use, et cetera. And now all of a sudden that's on your doorstep. Hey, Dr. Azar, I need you to take care of this for me. I find that to be a particularly difficult one because I think personally I had the reaction that a lot of us probably do, which is like, well, forget that. I'm not doing. They're the ones that did the surgery. I told them I would do it some way different than that, so they can handle the rehabilitation, phone calls, and all the things that happen with it. When in reality, when that actually happens, you can't, as the team physician, have that kind of stance. You don't have a choice because they're your athlete, that even if you didn't do the surgery, you have to kind of dig in whatever way you have to help the athlete along. So talk a little bit about that situation. I think particularly at the NBA and in the NFL and in Major League Baseball, that it's often a situation with multiple opinions and, not necessarily the team physician is the one to take care of it.
Yeah, at the end of the day, it's whatever the player wants, and then you take care of it. It's a small world. Orthopedics, we're 2.7% of all physicians, and the sports medicine group, with the foot and ankle, wherever it might be. We most everybody knows everybody in the circles,
mm-hmm.
and respects everyone too. So, I think that you got to do what's best for the athlete, and I think it is important to communicate if there's a certain type of rehab protocol that. Whoever does the surgery should really, I think, should be their protocol, whether they're
mm-hmm.
supervising it or you're supervising it. And first of all, I want to make sure you're in sync with the protocol, because that's, as the rehab is as important as the surgery. That's something that's got to be communicated too. So I think you just got to embrace it. It's a part of the game. As I tell my trainees, it ain't about you. You got day job. We have day jobs. This is about, this is the profession of these athletes are taking care of, whatever level it is, college or semi-pro or pro, and you do the best to take care of them in that situation.
On the flip side, but a similar note to that, how do you handle these cases in the off season? Similar example, you may do somebody's surgery there locally in Memphis, but they live maybe overseas, or they live in Seattle, Washington, and it's off season and they want to move home for a while. How do you handle that from a rehab standpoint? Is that something where they're making frequent checks, or is this contacting a medical team that is more from their hometown?
Yeah, if they're coming into us, we've got a place called Excel, which is a sports performance place. A former, and it's run by a former NBA athletic trainer. He was 17 years in the league, and he does a lot of training for the drafts, the NBA and the NFL, and sees a lot of baseball players in the off season, maybe from recovering from surgery. So we coordinate that to where we're communicating with their surgeon, their trainers, whoever they have, if they're in Memphis in the off season, whether they've got an injury or they're just trying to rehab from a surgery or an injury, or whether they just want to get ready for a draft or something like that preseason. So, but if it's something they're recovering from, we're staying in touch with their whoever did the surgery, and we're utilizing their post-op protocol and following that. And this communication is really important for that, as you know.
we've talked a lot about specific injuries in NBA athletes, specific knee injuries, as well as kind of the differences in taking care of team sports. One of the big ones that I know that I don't have any specific experience with is mixing in the front office and agents and contracts as those become more prevalent. And that did start to happen in my last couple of years of Purdue at the collegiate level as well. Once the guy gets the grade from having, even a few weeks of a good season, starts to be a little buzz in the off season that maybe they're going to be an NFL draft coming up in the upcoming year. All of a sudden the stakes change a lot, and especially with advisors and a lot of money being thrown at these kids now, even at the collegiate level. I would assume that someday that's going to continue to trickle down all the way to the high school level, and hell, who even knows? There may be a day now where middle school kids are going to be, I can see that it's not too much of a leap to think that Johnny, the 14-year-old that's a phenom throwing 90 miles an hour already, is going to have agents and endorsement people starting to lurk around, Zionsville West Middle School here where my kids go. So talk a little bit about that, the influence of agents and front office folks in the practice of sports medicine in the NBA.
Well, I think it's, again, communication is really important. I think it's important to try and get to know the players' agents if you can, to let them know that your door is open to communicate with them too. And certain teams like to communicate with the agent directly. Depends on the policy of your team, but we've got some local agents here too, and there's certain people, they bring their own people in, that too. So that's obviously those are people you're going to communicate with. But when you're dealing with one of your athletes who's got an injury, you just I always let the agents know I'm accessible. They usually get the information they need from the team, but just to let them know you're accessible I think is really important too.
So one more question that we didn't talk about is an evaluation of incoming players. That's something I started doing at the end. We'd get brought up at the end of my time up at Purdue. We would get brought up into recruiting days to take a look at players, and it was an interesting, different way of looking at things. I've never been involved in the combine, but Dr. Shelborn, my partner, kind of helped bring the combine here to Indianapolis, and was one of the real pivotal people in having it here in Indianapolis and running it the way that it is currently, as he was a team physician for the Colts. So talk a little bit about what it's like to have a player that the team's excited about, that they really want to have, that all of a sudden has an injury that you're really concerned about.
Well, that's happened more than once, and you have to do a deep dive into that injury and the consequences of it, and then you have to try and predict, what the odds are. This going to be something that's going to be a problem down the road? If so, you're looking at rookie contracts then for people like that. They're just coming in, and depending on where they're being drafted too, is it first round guaranteed or not, second round not? So a lot of things to consider. And you have to, the teams depend on you to try and forecast, and that's something you have to be willing to do, because based on your experience, based on data, based on a number of things, based on the player too. Those are all things you have to be considering. It's interesting. The teams have a lot of information on these players personally, and that has to go into it also, into the mix when you're making trying to make those predictions.
A couple things that I found that really helped was, not if the player has a history of injury, what did they do last year? If this kid's had a broken whatever and they've had surgery for this. Okay, well, the last year before they came to the college team that you're covering, did they struggle the whole season? Did they miss half of their games, or did they play the whole season? I remember a couple specific instances where a guy had an injury that they were concerned about, and you talk to the player. Yes, I had that 2 years ago, but you look through notes from their trainer if they're going to transfer, or if they're a new player to you, and say, what, last year they balled out and they played the whole season, didn't miss any time. That always made me feel better about something that could turn into a chronic injury if the player had played with it, almost regardless of what it was. If they played with it for a full season, didn't miss any time, and were effective, then I felt much better of that. The other one that I tried to convey sometimes to the team was, listen, this is an injury that is a risky one, but I think it's probably going to be okay. So if this is a guy that you're really high on and that you think we might not otherwise be able to recruit this guy to come play here, then I think it's a reasonable risk. If you have 10 other guys at this guy's position that you're equally interested in that don't have this injury, maybe you want to pass on this one, even though it's the same injury. Like, how interested are you, and how does that play into your recommendation?
Yeah, those are great points. When you're going from high school to college and college to the professional level, the seasons are longer, the competition's tougher. Those are things you have to think about too when you've got somebody who's got an injury that might be lingering, or maybe something that could shorten their career. But yeah, the history does predict, is probably the best way to predict some of these things too, for sure.
Yeah, and transfer portal, I think, has made it even more difficult, because at least if you're you have somebody that comes to the combine, you have a chance to look at them, you have some evaluation period before you end up to the draft. It's a finite time, and everybody drafts on the same day, versus transfer portal time. It's completely Wild West at the collegiate level right now. Once that transfer portal opens, there's 20 guys out, 20 guys in almost every year, if not more, through the transfer portal. And sometimes, hey, I'm bringing this guy in, we're going to offer him, we need to sign him because he's going to go down the street to Indiana, or to, he's going to make a trip up to Michigan if we don't sign him today. And those things tend to move a lot more quickly now with the transfer portal in play.
You can't say college coaches are ever paid anymore. Between the transfer portal and NIL, I mean, seriously, there's so many things to consider.
I was going to say something similar to that point of, especially at the NBA, what is 80% of the players drafted in the first round are 1 year removed from high school. And, if they played multiple years in college, they probably transferred or what. So you're trying to predict something that doesn't have the biggest sample size in terms of years. So that's got to be a tough job.
Well, the special ones you can recognize. You can look at last year's draft and figure that out. But yeah, it's just tricky for sure.
Yeah. Well, Fred, thanks for joining us. We was really looking forward to this night to talk to you about all this stuff, and you didn't disappoint. Some great information for the physicians and for athletic trainers, therapists that are listening to our podcast, to hear it from somebody with your specific type of experience. So I guess if we have any final thoughts about the management of NBA athletes with knee injuries, what final thoughts would you like to leave our listeners with tonight?
What's probably a broader thought than that is, when you look back on taking care of athletes and their families and people that are motivated to get back to what they want to do, what they love to do, what they're blessed to be able to do. The relationships you form along the way, really the most gratifying part of being a sports medicine doc. And so take some time along the way to try and, communicate with people and stay in touch with people, and that part of it's the most gratifying. So we're pretty blessed to be doing what we do as orthopedic surgeons. And I think the sports medicine side is another level of relationships you can establish from when you're taking care of these athletes and their people around them.
Yeah, no doubt you get bogged down sometimes with the decisions and the pressures and everything. But I can tell you, a couple times stood on the floor during introductions at Mackey Arena, looking around, going, how lucky am I to be able to do this? I'm sure you probably had that a couple times where, working a playoff game at the FedEx Forum, looking up, thinking, man, am I lucky to be here?
For sure. Certainly feel blessed to have been able to do this.
Yeah. Well, thanks again, Fred, for making some time for us tonight. We really enjoyed having you on, and some great insights. Next week the next couple weeks we'll be back with a new episode. If you'd like to find us on social media, in the meantime, Facebook and YouTube, the Shelbourne East Center podcast pages, at the SKC Podcast on Instagram and Twitter, and you can email us at the skcpodcast@gmail.com if you'd like to contact us. Please check out our previous episodes. We've got a lot of content up. We've been doing this for quite a while now, about 35 or 40 episodes, and a lot of good stuff that I think you can learn from. So pick up any of those. And if you'd like to leave us a comment and make a follow so you don't miss any future content, we'd love for you to do that as well. So thank you for joining us, and we'll see you next time on the Shelbourne East Center Podcast.